Okay, let's get started. Good afternoon to the people in New Zealand. Good morning to the people in Australia. My name's Mark Cox. I head up business development for MEG in this part of the world, Australia, New Zealand, Southeast Asia. And we've got a really good session today with Sandy and Tamsin from Waitemata, looking how the use of MEG and electronic auditing helped them improve quality during the COVID pandemic. Just before I pass on to Sandy and Tamsin to do their introductions and start the presentation, just a couple of housekeeping rules. We're going to have a Q&A that will just be done through your Zoom app. So there's a Q&A button at the bottom of your screen. So just submit your questions through that. And I think it's about half an hour into this presentation, we'll then switch over to the Q&A session. This session will be recorded, so if you have a problem with that, I know what you do, probably disappear. Yeah. And at the end of the session, for all those who have attended, there'll be a draw for a tablet that I have here, and Adele will be using a special app to manage the random generator for that. So moving forward, I'll pass it on over to Tamsin and Sandy to get the presentation, introduce themselves, and then get the presentation started. Thank you.
Thank you, Mark. Kia ora tātou, everybody. My name is Sandy Gaiman. I'm the Infection Prevention Team Lead for Waitemata.
Kia ora tātou, ko Tamsin tōku ingoa. So I am here in my role as the COVID-19 Executive Lead. My substantive role is the Chief Allied Health Scientific and Technical Professions Officer at Whatu Ora Waitemata. And I worked very closely with Sandy during our COVID response, and I'm really happy to be here to support her, she's done the lion's share of this presentation today. I have one slide, so feeling a little bit like a fraud, but very happy to be here and answer questions and support.
Thanks, Tamsin. Okay, so just to tell you a little bit about our world, Te Whatu Ora is the New Zealand health organisation, recently formed, and Waitemata is the name of our district. So our community serves Auckland, all of North Auckland and West Auckland. It extends, as you can see in the map, very far north to Rodney, North Shore, Waitakere, and up to Wellsford, and then down in the south to the Harbour Bridge, for those of you who are familiar with the Auckland region. Who makes up our community? We have the largest population in our district of 630,000. We have quite an ethnically diverse population, 10% Māori, 7% Pacific, 19% Asian, and the remainder being European or other, and other includes Middle Eastern, Latin American and African. So as you can see, we are a very diverse district. We deliver services across multiple sites. We have North Shore Hospital, which has an elective surgery centre. We're currently building a new hospital on this site, which will have 8 theatres and a number of wards. We have a mental health site, and we have medical and surgical wards. We have Waitakere Hospital, which has medical and surgical wards, community dialysis, and an older adult mental health building. And then we also have a third site, which is the Mason Clinic, which is forensic mental health. We also provide a range of services in the community. However, it's important to note that we do not provide any infection prevention coverage of the aged residential care sector. Just to set the scene, the national picture in New Zealand is that at the start of March, the 16th of March, a 14-day quarantine for overseas arrivals was implemented. So this was way back in the days of Delta, when we had seen COVID outbreaks overseas, and we were still in the stamp it out phase of our public health strategy. On the 19th of March, the New Zealand government banned all indoor events with more than 100 attendees. And on the 20th of March, the New Zealand border was closed. On the 25th of March, the New Zealand government announced a total lockdown across New Zealand. And this was, again, part of the stamp it out strategy for New Zealand, which was very effective for quite some time. It wasn't done in isolation. It was done as part of the team of 5 million was the catchphrase. And so the whole country were part of this strategy. And on the 10th of April in 2020, there were 44 new cases, which left us with 1,283 in total across New Zealand. Just to bring you into the situation of what was happening in Waitemata, on the 10th of April, there was an outbreak of COVID in an aged residential care facility. And some of these patients were transferred to Waitakere Hospital because, as well as an outbreak in the patients, there was an outbreak in the staff, and they were unable to provide care for these acutely ill patients in their own facility. The patients were elderly. They had a wide range of comorbidities, including cardiac and respiratory. They required specialist care and constant monitoring by ward staff, and they had quite high acuity. At this time, all PPE donning and doffing was recorded on paper, and the staff on the ward at the time reflected that PPE supplies were constantly disrupted, so they were constantly being given different PPE, N95s in particular, and this was due to supply disruption. On the 24th of April, a first staff member became symptomatic and tested positive on the 27th. Subsequently, 3 more staff became positive. We put together an outbreak timeline, and we established that they had all worked together on the same ward on the 20th of April, and they had all cared for the same group of patients. There was a request from the Waitemata senior leadership around a need to understand how these staff members became infected. And one of the recommendations that was made post-investigation was to add a buddy system to the PPE guidelines and checklist. So that meant that all healthcare workers going into and out of a room with a COVID positive patient were supported to don their PPE and audited when they were coming out and doffing their PPE. There was a problem with the system, however, that the system relied on paper audits, that we had to upskill a large amount of people in using paper audits all at the same time. On top of this, the staff themselves were unfamiliar with the donning and doffing process. There was no clear process for escalating any breaches, and I've already described some issues with the PPE. This meant that there were no assurances to the senior management that a PPE breach was not the source of transmission for our staff outbreak. When we looked further, we realised that the dissemination of reports based on the audits was often delayed by workload and by ongoing outbreak management, not only on this ward, but as we identified further COVID positive patients throughout the organisation. There was no clear way for a fast escalation of PPE breaches, and there was no way to collate the data to establish common causes. There was also lots of pressure on our executive leadership team from the Ministry of Health because of the fact that we had had staff who had developed COVID from their work on the wards. So we had implemented electronic auditing for another purpose within the organisation, and we felt that this might be a solution for the donning and doffing. Our aim was that it would quickly and effectively identify compliance issues and provide real-time feedback Because it was easy to use, we felt that it would enable high staff engagement and therefore rapidly develop the quality improvement strategies that were needed at ward level. As the numbers of COVID patients increased in the organisation, we needed the software to have rapid scalability. So we needed to be able to increase the number of audits being carried out and across a larger range of departments. The software needed to be user-friendly. It needed to have a rapid interface to allow quick data entry, because the staff, as you will be familiar, were entering rooms to give patient care, and they didn't have a lot of time to be donning and doffing. They had lots of other things to do. We needed a way to rapidly identify common issues and threats. We needed to be able to provide a robust audit trail. And we realized that we needed the software to be usable across multiple platforms. So in the end, in the organization, we established iPads, Android phones, and computers on wheels were the main ways that people were entering data. So on the left, you can see our paper audit. Apologies that it's not as clear as I hoped it would be. So this was filled in for every single time a person went into a room or left a room, and it was quite time consuming because they were filling it in by hand. Once we established the electronic software, all the content went to the cloud, which meant that it was being analysed in real time and that issues were being emailed in real time to the people who needed to know. We realised that the paper-based auditing was poorly completed because people were time poor, and so they were cutting corners. If a breach had occurred, often people thought, well, I will tell somebody about that once I've got this person into the room or out of the room safely, or once I've completed the next task that I need to do. The record keeping was inconsistent, so people had different ways of filling in the forms. However, there wasn't any additional resources required once you'd photocopied 1,000 copies of the audit. There was no feedback of the audit data unless somebody took the time to go through the paper audits and prepare a report. And it was unclear how many audits were being carried out, and that's because there were a number of audits being done over a number of areas. So it was really difficult to work out exactly how many episodes were being carried out at each time. The electronic auditing had to be fully completed before being submitted, so you couldn't cut corners. You had to say yes or no to every question and identify the issue. Once an audit was submitted, an email was sent immediately to the charge nurse manager, to the infection prevention team, to the PPE coordinator, and the COVID exec lead, all at the same time. So there were lots of eyes on each email identifying breaches. Because the records were cloud-based, we could all access them at the same time. However, we did have to invest in some more electronic software, for example, iPads. And this was particularly relevant for some of our community sites and our mental health sites who didn't have iPads. What we did find was that it allowed the management team to look at results over time and trend them, and therefore they could focus on areas that needed attention very quickly. And the total number of audits done by the end of 2021 in Waitemata was 36,000. Just to reiterate, the charge nurse managers stored the paper audits and sent them to the executive team once a week. They did review them when they had time, but it was a large amount of paper every day. However, on the right, you can see we got an instant view of the types of staff that were being audited, and you can see that it wasn't only our healthcare workers, but it was others who came on site, such as funeral directors, etc. So the outcomes. So once we had implemented the MEG software, We had rapid targeted action by infection prevention, which was driven by the real-time issue identification. So we could see breaches and issues in real time, which meant that we could give specific education. And this was really useful because the infection prevention team at that time was really small. It's only 4 of us. So we needed to be very smart about how we targeted our activity. There were less phone calls and emails from senior management around concerns around PPE. Improved practices by healthcare workers, as the auditors were also able to use the audit as a checklist, and they were able to troubleshoot in real time. And about 6 or 7 months into the audit process, we actually stopped auditing donning completely because we had not identified any issues, and we only audited doffing. Scaling the use of the app by having a link on the intranet, which is our sort of internal website for the hospital. And that meant that all areas could easily access the audits. This was important because as our COVID numbers increased, not all patients could be housed in one area. So we had to make sure that all areas had access to MEG. And the charge nurse managers really liked the fact that they could own their own data, and often they had put actions in place by the time the infection prevention team went to the wards. The final and very important outcome is that we had a happy senior leadership team.
Thanks, Sandy. So you've already heard Sandy talk about the spread of our organisation, and many of you will be joining us from organisations that have multiple sites across multiple ends of your districts, and that gave us an added complexity in terms of getting data in a timely way. So for me, in terms of reporting directly to our Chief Executive and to the Ministry, many of you will have been involved in gathering some of that data in your own areas. Having that reporting directly arrive in my inbox at the change of each shift with really clear outcomes, identifying areas where we may need to do some top-ups in terms of teaching, or just going back in and doing a quick recheck, just made that reporting so much quicker and easier. And it meant that I could also click into the dashboard, understand where the issues were, understand why we may not have got 100% on that day in that area. It came with that ability to give us that, I guess, free text and updated information around what had been done at the time when a breach was uncovered. And it meant that I was able to settle some of the concerns that we had had across the organisation as a result of the outbreak that we had in our initial intake of patients from that ARC facility. In terms of other supports, and I have to say it's continued to be a support even now as we have made this, our COVID response is now our business as usual. We certainly don't have the same eyes on it that we have had in the past 3.5 years, which is nice and refreshing. But it means that we've got that level of detail there when we need it. We're able to go back when we get queries, media queries, OIAs, union partner queries, and we can look at that in the past and see how our travel and traversing across that process has been, and give them really clear evidence-based data and have really strong conversations around what we've done and what we're doing and our process in the future to continue to have those eyes on when need be. Another big initial benefits was that releasing of staff. So if you think back to Sandy was talking about the paper audits and having donners and doffers being checked by a PPE checker, that immediately released all of those people to be actually back into clinical care, back to their substantive roles to support our ongoing COVID response. So rather than having that double up of people, we actually were able to release those people back to doing other things, which was overnight amazing and made a massive difference to some of our key areas. So I guess the kind of key messaging from me in terms of if you're considering going down this pathway that we have done is that the ability to have all of that information at your fingertips in a way that is completely accessible, interpretable, readable, but also gives you a really substantive evidence base for ongoing future conversations, it did make an immediate difference to us and to our approach and our ongoing approaches in terms of our infection prevention control space to this day. So yeah, I absolutely have to say thank you to Sandy and the team for driving that for me and for the organisation.
Thanks, Tamsin. So one of the outcomes after we implemented MEG is that we had submitted 36,000 audits, and MEG gave us an award because we had submitted more audits than anyone else in the world, which meant that we had tested their system to breaking point. It didn't break, it was perfect the whole way through, and they were very relieved, and we were really grateful actually to get the award, so thank you for that. The software was widely accepted by users of all skill ranges. So at times we had healthcare workers using the software, and then at other times we had other healthcare worker groups using it. And because the user interface is easy, it was quick to teach and people to pick up. So just in closing, the lessons learned from me are that things can be done very quickly in a pandemic. Sometimes I hanker for those times. Decisions around purchase and adding links to the internet, for example, happened rapidly because there was a real need and a real drive to have these things done. The tool, whichever tool you choose, needs to be easily adaptable as the pandemic progresses. And we did find that MEG was adaptable, although I learned that you can't make changes to a live audit because there's data already in the system. So that was a really good lesson for me as I broke the system one morning. And finally, I would recommend using a digital system wherever possible because it is easy to change. It has less impact on the staff. And when you compare it to a paper system, it provides less stress in the system. Thank you, Mark.
Excellent. Well done. Thank you. Time for Q&A. If anyone's got any questions, I've got one to start with. And I can't remember what was the time period it took to when you decided to go, or it's probably 3 years ago. How long did it take to get you started and underway on using the electronic tool?
We were very fortunate to have the software in the organisation already because coincidentally we were trialling it for another purpose. But I would say it took probably 2 months to convert over to the donning and doffing and get it scaled up across the organisation.
Right. Any other questions from anybody? Here one. Is it easy to write your own audit within MEG?
Yes. So MEG have a process where you submit your audit, whether it's a Word document or an Excel file, to them, and just let them know how you want people to be able to record the answers, whether it's multiple choice or radio buttons, or you can have yes to all. So all your answers can be pre-populated with yes, and then you just go in and change the ones to no or create an issue. So yeah, you can do that, and it comes back within a couple of days.
Right. Was there any concern about contamination of the iPads on site during COVID by the users?
No, because the users were outside the room. They weren't auditing in the room. So they were only auditing people entering or leaving. They weren't actually in the room with the COVID patient.
Okay, one from Glennis. How did you know that the doffing was done correctly and there was no contamination at the time of doffing?
Because they were directly observed, Glennis.
Did MEG have teaching tools to teach end users and those analysing the information?
Yes, they did. They provide user guides, and then that's just followed up by, in our case, it was our team, but it could be anybody who's familiar with the MEG system.
And training's quite quick, or do you use videos or things like that, or how you know, a lot of users, how did you train those users up, or didn't require too much training?
Yeah, there's a user guide. So when people get set up as a user, they get given a link which had a user guide, and then it almost became a trainer system after a while. So the charge nurse was very familiar, so was the coordinator, and then she would make sure whoever was doing the auditing on that day had used the system before, and if not, she would show them. And Tamsin would know if any audits were coming from an area, and then we could follow up and see whether that was a problem with the audit.
Yes, I could very quickly see the gaps across the organisation, and would have a conversation with Sandy or one of the team, who would then go and follow up. And I have to say, from someone who wasn't using it on a regular basis, when I did need to go in and have a look, it was very user-friendly, very intuitive, and it certainly didn't take me very much training at all. So I think that's a good benchmark.
Okay, Paul, were you able to easily convert the audit results into the reporting format required by government authorities?
Yeah, I think that was one of the benefits, is that because of the way that the reports come in and the way that it is adaptable to your own needs very quickly, it meant that we could frame that data up in the way that we needed to extract it into any reporting that we were doing on a regular basis. I often got very short notice requests for information, and it certainly helped me to pull that together within the timelines versus having to find piles of paper and go through and find the right shift and the right ward on the right day. So absolutely moldable in terms of what your reporting requirements are.
Cool. How easy was it for loading staff and auditors onto the system? Was it time consuming?
So it can be done in two ways. Initially, when we set the system up, we gave all the names and all the emails to Meg, and the Meg support team set the users up. So that was about 80 plus. And then after that, as new users came on board, my team did it because the numbers were a lot less per day. But the initial setup, yeah, was done by Meg. Good,
good. Okay. Was auditors allocated to a ward, or did an auditor cover multiple wards?
So auditors could, so on a particular day, an auditor was allocated to a ward, but that auditor could then go to another ward the next day and audit in a separate area.
What other audits have you put into Meg?
So from an infection prevention perspective, we have an environmental audit, a quality audit, we have each patient that's put into transmission-based precautions has an audit completed to make sure that the room is set up properly. The respiratory protection program have an audit on there around mask fit testing. There's 17 in total on there currently. Our resus team have just started using Meg to audit their resus trolleys, and that's enabling them to identify common themes really quickly. They're really enjoying that.
Oh, I think that's about it. We've got a lot of questions. Just before we go into the draw, any more questions? Anyone got any other things before we go? Okay. Okay. Anyway, if you've got any questions, let me know or let Sandy know. My email is mark@megit.com. And we're going to do the draw for the tablet. Oh, here we go. What Glennis has asked, what's the cost of the software? Well, Glennis, that depends on the size and the number of audits and all that. So cheap, isn't it? Yeah. So yeah, it really depends on the number of audits and the size of the hospital. That's the main thing in terms of cost. You get a bundle of 4 or 8 or 20 audits for the size of your hospital, and the aim is that try and not put any restrictions on the number of users, so you get as many people using the system as possible. So if anybody wants to do an audit, get them on the system and put it on their phone or the tablet and get them going.